Hi friends, today we'll discuss something related to surgery paper 1. Okay. So firstly, let me give a disclaimer before the starting of the video itself. Surgery paper by default is unpredictable for the fact that if you date back to the history before general surgery was asked just for the whole paper what you are studying was asked for 50 marks before. So the number of RS questions, that is single questions, are less, and invariably you will have more of competency based questions which you need to focus when it comes to surgery paper. The only paper where you need to focus on competency much than the RS question is surgery paper 1. Though these are the topics which are possible to come for your, though these are the only topics which are present, there are many things which are written generally, but it's not general when it comes, though the topic itself is general surgery, you need to give them a specific points related to whatever you are studying. So let me be very clear at the start, in the beginning of video, this narration of general surgery paper 1 will not go according to your previous narration which we had bought, just for the fact that the paper has evolved itself. Okay, so these are the topics which is there in the paper 1 of general surgery, which you will be writing for 100 marks. Okay, so general surgery, then roughly above diaphragm, if you say me, though the endocrine part is below diaphragm, and CNS part, there is neurovascular neurosurgery is under paper 2. So these are the topics which you need to study for paper 1, that is general surgery, then facial anomalies, oral cavity, skin lesions, then minimally invasive surgery, trauma, thyroid, endocrine, breast, and one more, something to do with research related questions, of all which I have given you the flowchart answers so that you can go through that part. So firstly, the pattern of surgery has evolved after introduction of CBME. RS questions are less in individual event, so competency based, nothing can replace competency based competency in surgery paper 1. Okay, so this book comprises, or this PDF comprises only of RS questions and not of all those things. So please study based on competency. This, let me be very clear, the nature of the paper itself is unpredictable. These are made based on 4 papers, that is 2 and 2, that is 1 year plus new paper, that is fresh paper and supply paper, and new paper and supply paper. So only these are the things which you have. So based on things I need to form things, because in previous papers what used to happen is, even RST, there used to be a specific idea or specific aim what the examiner wanted to test, but here the pattern itself has changed. Only with 4 patterns it's quite tough even for us to predict the paper. So this is what is followed in 4 papers. Okay, but let us see how it goes. So basically, from even in the past 2 years, only a CBQ based on thyroid and breast is being asked, and I think probably one question related to general surgery, for example a blood transfusion type of question, or a nutrition based of question, or any surgical investigation based of question, can be a 10 marker, again. Everything in this paper is can, not must. Let me be very clear. Okay, then again coming to the 5 markers as such. So any 2 questions will be from proper systemic part, that is under oral cavity. You might, again under oral cavity you have salivary and non-salivary, anything you can get. And again under endocrine, men, adrenal or paradenoma or parathyroid, any questions related to that can come. And again 2 to 3 questions can become is sure from general surgery. Again blood transfusion related question, anywhere in 10 mark, 5 mark, 3 mark you will get. And again you might get questions based on wound healing, burns, nutrition. These are like core general surgery topics which you need to know in and out, even shock. Okay, then one research related question is what I feel is like sure, and one question related to minimal invasive surgery, for example advantage or disadvantage, or principles of the surgery, for example principles of laparoscopy. Then something to do with skin lesions of malignancy. This is like, for example, you might get SCC or BCC, something related to that. Okay, then The three marker, I don't know what to say, because even in previous papers you cannot predict, and come on, say me, how can you say in this paper? This is like general overview. So again, one question from oral cavity, one from endocrine, and these are like again two from general surgery, something related to surgical procedures or ethics. Ethics related one question is like kind of short as for four papers, and one question from organ transplantation is something anywhere in 5 marker and 3 marker, and some examination of what you had studied, like same how it goes with medicine, and triaging related question might come. Okay, so with that note, I will start with general surgery as such. So this notes is like, see, there is nothing, let me be very honest, there's nothing, there's no any involved concept which is there in paper one of general surgery. All paper, any general surgery ka concept which was there is already explained in patho. Medicine had some concept I've explained, ortho how to approach that paper I've explained, but in surgery, what is the main thing? It's a basics. So again, let me go with this was asked for 5 marker, 5 marker or 3 marker. So in and out. Okay. I know while seeing the paper you might feel it's very general, but problem with very general topic is that you cannot fill the pages, or you cannot give the content relevant, because for something which you feel general might not be a general topic to them. They expect you to answer some specific things. Okay, so again, make some mnemonics, remember for that point, and just forget it off. Again, investigations in a surgical patient, obviously these are the this is like common sense. First you do the basic investigation, then you do the imaging investigation like CT, MRI, ultrasound, then you do special investigation for all the fitness which you take, and pre-anesthetic check. Again, if you want some mnemonic, obviously you can do, but I am not a favorite fan of mnemonic, but you can just remember BP is, because you have to check for yeah, BP also before a surgery, so you can just remember. But again, go in an order, because this forms a perfect sense than this form. Okay, then obviously you need to take an informed consent. Again, okay, ethics. So four mantras of outcome which is there, that is autonomy, beneficence, non-beneficence, and justice. So you need to mention about this also. So make sure you write about these things and explain what is that. You have to apply your moral principles, those adcom classes which are sat for hours, no, so those things when you apply it is called as ethics. And how do you use that? You can give it first write about the basic principles which is involved, then how do you apply it in an informed consent, then to take the best decision for the patient so that the patient is not harmed. So these are like for 3 markers specific. Make sure you know that, because this is like, I'm not giving a mnemonic for you, because I think you would have had more classes on AdCom than general surgery itself combined with all 19 subjects. So I'm not giving any mnemonic, because every day, every weekend you would have done all drama events, and also I think that should be fine. Then second topic, wounds and wound healing. This is the core general patho topic. Let me be very clear. Okay, so what is a wound? Again, wound or an ulcer. Again, what does Bailey has to say? It says that whenever there is a integrity in the whenever there is a discontinuity in the skin or mucous tissue associated with microscopic tissue damage is ulcer. Okay, but here in wound, it's not something to do with microscopic, because you already, its wound is something which you can see, correct? No, then again, there are many other classification which is given in 157 page number of SRB, but I have just written this one. Again, there's nothing to understand. It can be a clean wound, or it can be clean with contaminated wound. What is that? Whenever you're doing an operation, when you spill the contents of abdomen, then it's called as clean, because the environment was clean but you contaminated with fluids. Okay, then again, contaminated or dirty. Okay, then again we have to give examples. Then infection rate is also something which is mentioned. I'm sure you won't remember this, but just for the completion sake I've written, but make sure you classify it accordingly. Then yes, you classify it accordingly and place it accordingly, so that you don't lose upon things when it is required. Okay, contaminated, dirty, clean, and with what is that, and with an example. Okay, then how does wound healing takes place? Pathology, there's nothing much which I need to explain in this part. Again by, it's either primary intention or secondary intention or tertiary intention. So though these are the main things which is involved, what happens in primary intention? The wound edges are already approximated, so how does it heal? Via reepithelialization. So whenever the wound edges are already approximated, it yields under obviously reepithelialization. But what happens in secondary thing? What happens in secondary thing? In secondary healing, there is extensive soft tissue. I'm sorry. There's extensive soft tissue damage. So what happens whenever there is a soft tissue damage? For example, here let us imagine there is a soft tissue damage. So epithelium is lost. So it heals by fibrosis. Okay. So there will be contractures. Then what is healing by tertiary intention? After you do the wound debridement and when you suture it, it's when healing takes place in primary contaminated or mixed tissue. It is called as tertiary intention. Though these are the only main thing, this is a part of it. Okay. Then phases of wound healing, again the same Robbins thing. I don't think I have to explain here. You have the inflammatory phase. What happens? A blood vessel, when it comes out, you have the blood which gets deposited. Again you have all the macrophages, fibroblast, which is again at the proliferative phase, that undergoes remodeling and forms a type 3 to type 1 collagen. Okay, that is called as remodeling. Then what are the factors affecting wound healing? Local factors and general factors. So what are the local factors? That means at that place what are the things which is important. So you can just make some mnemonic here. So uh, some you make sure, than making a mnemonic, what I would feel is better is make sure you know what are the important things in this part. Okay, for example, okay, the most important thing which I feel is important in this part is, okay, you have to talk about the wound infection part, the blood supply, because healing takes place based on that, and site of wound, because if it happens in a joint, then obviously the wound healing is less. Then type of wound, whether it's dirty, contaminated, and hypoxia and blood supply almost means the same, so you can mention about that. Then general factors, again you have to talk about the same thing. Okay, again you have to talk about the age, nutrition, comorbidity, systemic condition, drugs, and also all these things, that is your immune mediators. Okay, and antioxidants. About both these things also you should mention. Okay, most important. Then obviously, yeah, that's what. There's nothing for me to explain. You have to go through it and explain. What about the keloid? Whenever this whenever there's an abnormally stretched type 3 collagen tissue bundles at the plane of epidermis but extend beyond the original scar. So make sure you underline these two, type 3 collagen and beyond the original scar. Then these are the most common side. How do you treat it? Recurrence is so very common, but you can give intrakeloidal triamcinolone, or you can go with laser therapy, or you can use both. What is hypertrophic scar? It is within the margin of wound. This is the major important thing. And how do you do it? Again, it's the same thing. Okay, how do you prevent it is something which you can do, but treatment is again the same. Triaging, one 3 marker. I know it's a community medicine topic which you had studied. So this is the protocol which is given. So what do? You check whether the patient is walking or not. If he's walking, command a green tag. If he's no, then assess breathing whether it's there or not. If it's not there, then obviously try CPR. If no, then obviously it's black tag, which means he's already dead. So no priority to this patient, no priority to this patient. Then again, if he's breathing, then assess whether he has shock. If no shock, then wait for this patient. Then if he is in shock, he is your patient. Okay, so I explained it. So I think there's nothing more to explain here. So mention about the aim to save maximum lives with available resources. Then this is the algorithm which is given in SRP. I just explained it. Okay, then something to do with ERAS. This is Bailey and Lauka it's a graph. So what happens is that via this is the functional capacity, and also how much time it used to take. For example, you see days and weeks. So what happened is, what is enhanced recovery after surgery is that whenever the traditional care was taken, so you can see that the curve used to be very deep, very steep and long. So curve is very steep and long. But what happens if it's when you do the multimodal areas intervention, which we'll discuss in the subsequent slides. So what happens is that it is shallow and short, shallow and short. Okay, so make sure you draw this graph, and also mention, I mentioned about eras at the next subsequent slide, so make sure you write about that. Okay, then infectious disease, short 5 marker again. Okay, so tetanus was asked for 10 marker, but always study that. And AIDS I have talked about in infectious medicine also, so I'm not talking about that. And these are the major things. So again, whenever you're drawing writing about infectious medicine, what will you write? Etiopathogenesis, if asked for 10 marker. Clinical feature divided into general, and write what are toxic look, then fever, all those things. Then systemic feature, based on which system it affects, whether it is RS, whether it is CVS, whether it is CNS, right about that. Then any differential if you want to mention. Then investigation, again for investigation, basic again aims of investigation: to diagnose the condition, to look for complication, to prevent recurrence. Again in recurrence, what will you write? You can write about vaccination and hygiene if required. Then again to look for complication, mention about all function tests, for example liver function test, renal function test, and any specific organ which it affects. Then to diagnose, what is the basic thing which you will do? Again CBC, what will be increased? TLC will be increased. And again you can write for microscopy if it's a bacterial with culture. Then if it's a parasitic, you can also order a stool culture. So this is the basic template. Now try to fit under this, even for medicine or for surgery for that matter. Then try to extrapolate. So now whenever you are studying based, and also complication, local and systemic. So now and treatment protocol also, you have to give antibiotics for bacteria, then antiparasitic for helminthes, and viral you just give a general support. So based on this template what you have, it's your aim to fit those diseases. So you should not learn anything. For example, now let us go with, you have understood the narration on how all these things goes. So now what is the things for which you need to study in erysipelas? Obviously causative organism, the same thing which I mentioned, but in examination you write about this. Okay, that is cellulitis near the earlobe. Then also the same things. What is the treatment? You give penicillin or clinda. Again you need not remember it, because what is it? It's a streptococcus, so it is sensitive to penicillin. What is that? Except these two things, what is the extra thing which you learn? Nothing. So make sure you know what you form a general template, then go with the same narration. Okay, then again pyogenic abscess. So obviously whenever there is abscess, what does Bailey say? Drain it, drain it, drain it. Again, when throbbing pain is because whenever there is a abscess over here, the nerves which is present over here, it affects the nerve, so you will have a throbbing pain. So that's one of the clinical feature of any abscess. You can write that blindly. Again the same thing which I told, same investigation, same complication. Again the important thing here is you might have sinus or fistula or abscess and antibioma formation. Again the major thing which they expect you to know is this. So write about the Hilton's method. This itself is a 3 marker. Okay, you have to start them on first you have to drain it under GI or local anesthesia. Abscess should be aspirated. Then I'm sure you would have all done this. Again you have to open the pyogenic membrane, then you have to break all the loculi, then you have to add saline and drain whatever is required, then start on antibiotics. Don't simply start the patient on antibiotics if abscess is there. Okay, then what is carbuncle? So remember uncle. Who will get diabetes? Uncle. So in a diabetic patient, if you see any this kind of skin and severe soft tissue, soft condition, subcutaneous tissue involvement, then it is mostly caused due to Staph aureus. So then it's a carbuncle. Okay, the same thing. I'm not talking much. Okay, but what is in the diagnosis? You write this thing. Whenever you see a carbuncle, it's your duty to rule out diabetes mellitus. Okay, treatment, again the same thing. Then what is Pott's puffy tumor? Is it a tumor? No, it's a diffuse external swelling in the scalp due to trauma or any sinusitis. Since its sinusitis is present, you have to talk about that. Okay, Then gas gangrene, yeah, this is a 5 marker question. Again, I think it was also a 5 marker in your microbiology. I am sure you know this. But major thing is this and this. These are the subtypes which are there. So basically, what are the skin, subcutaneous tissue, then you have muscles, then you have tendons, then at the end it can enter systemics. Based on this, they have done the clinical types. Okay, again, make sure you write about all these things. What is the treatment, till where it has been where you can find it's non-viable, you have to do amputation. Remaining this, it's an it's an anaerobic infection, so you have to give metro. So I hope you know this concept. For all anaerobic things, above diaphragm you give clinda, below you give metro. So this is one important concept which you need to know. The necrotizing fasciitis. So what is happening? There is necrosis of what, skin and fascia. Okay, in skin and deep fascia. Okay, it can be of different types. Either one microorganism is involved, or many organisms can be involved, or it might be a fungal predominant disease, or it might be a mm, it might be a gram negative rods. Okay, after minor trauma. These are the 3 stages. Okay, first stage, obviously everyone will know, that is fever, erythema. Then you'll have blisters and bulla formation. Then this is the main stage. Okay, so after he recovers, then you have to give us you have to do a spleen script graph. Again, universal precautions, I think in and out you have studied in micro for 3 marker or 5 marker. Again, there's nothing. Divide it and just study. Okay, I don't think I need to explain. So obviously you have to do a personal protective measures, that you have to use gloves, then you have to wash your hands, then you have to keep instruments safe and your environment safe. And if you have an exposure, go take post exposure or post exposure prophylaxis. Okay, then tetanus, yeah, it's an important 5 marker or a 3 marker question. Obviously you know all these things. Again, the pathogenesis you can study if it's for like 5 marker or a 10 marker. Okay, then incubation period not required, man. You are not studying microdia. Okay, then period of onset is also not required. Okay, if you have to fill pages, you can. Then divide it and just write it out. At the end, what happens? Respiratory failure and how he dies because of all these things. But if you intervene before here, it's almost an 100% fatal disease once it is developed. So what is the treatment? Prevention, prevention, prevention. So what are the signs? Trismus. Then all these things you will write. I am sure you know about it. While writing classification, divided into general and systemic. What will you write in general? For all infections, septicemia and death. And all these things, I'm sure if you go through it, you will understand. These are the goals. Major goals which you miss is prevention. Because if you don't prevent this disease, once it occurs, it's a deadly disease. Okay, so whatever, if you can prevent us circulating toxins from bounding by immunoglobulin, well and good. Then to control the spasms, you can give benzodiazepines. Then to control ANS dysfunction, you have to give again Maxelf and all those things. Then eliminate the source of toxin. Okay, these are the general measures. These are the specific measure. Once it lands up in RS bar CNS complication, it is very difficult to do. Then prophylaxis, in and out, in and out, we should even with pregnancy, even with child, in an adult. This we are studied in this will study in pediatrics, and this will study in OBG, and this we are already studied in medicine every year. So I think even Dom, Dick and Harry knows that he do not be a medical person to know. Every 5 years once you need to take a TT injection. So that's why booster once in 5 years. Why? There's a concept behind that. What is this? The thing is, it's a toxoid. Okay, it's a toxoid, and you need to wake up your system. So when you will give first time at 6, 10, 14 weeks, again you will come and you will give a break, and you will give at 16 to 24 months. Again you will give a break and give at 5 years. Then repeatedly every 5 years you need to give, because this is the concept. This is how toxoid are effective. Okay, but all live vaccines, once 2 doses enough. If you want, you can give 1 booster, right? But this is the toxoidal effect. So understand the immunology part while studying vaccination, that we'll do in NIS. Okay, so this is what I wanted to talk about prophylaxis. So I just mentioned about it. Then shock, in and out of shock you should know. I know from physiology, from pathology, all there it was 10 markers. Again in surgery it is haunting us. So again this is the and also SIRS again 3 markers or 5 markers in acute critical medicine. I had not discussed there, so I'm just discussing about that thing here. So what happens is whenever there is an infection, so that will what is the body's inflammatory response to that is nothing but systemic inflammatory response syndrome. So this is the diagnostic criteria. So what is involved? 3 examination findings and 1 laboratory finding. This is to confirm your infection. This is to look for your RS CVS involvement, and this is general involvement. So divide and study. See how easy it is. Then causes, yes, it might be infective etiology or non-infective etiology like burns, which is more common. Then this is the clinical significance, that it's a part severely if SIRS has developed, that means it's already entered into severely decompensated reversible shock, okay, which will definitely lead into MOTS. MOTS is what? What is MOTS? MOTS is multi-organ dysfunction syndrome. Okay. Then shock again. You might feel difficult to remember this. Remember a mnemonic called ANS, that is anaphylactic, neurogenic, and septic. Then this is the major classification, which is hypovolemic, cardiogenic, and distributive. I don't think I need to explain shock because in and out you are studying from first year, second year. So again, I've explained about hemorrhagic shock because that is what is more common here. Because cardiogenic is something to do with obstruction and all those things. Distributive is again topic of medicine, not important for us as a surgeon. So hemorrhagic is what we do. Again, clinical feature, these are the major important things which you need to mention. Again, talk about every system, okay. Whenever you write about system, the clinical feature has to flow from your hand, because you have already reached the stage where you can just answer your paper just by classifying and just writing few points. So what is shock ratio? When pulse rate by SPP is measured, and if it's more than 1, that means the patient has gone into shock. Complication, same continued clinical feature, if not treated, will lead to complication. Okay, then what is the aim of investigation here? To assess the severity, to find out the etiology. Major is to look for complication. So mention about that. Treatment, first is what? Stabilization of patient. Again, evaluate for the severity and treat the specific cause to achieve the cure. Again, what is the major thing? You have to mention about ABCD, then hemorrhage and drain pus if it's required, then crystalloid has to be cleared because it is equivalent to your plasma. Then all your inotropes has to be given later after giving fluids, because without fluids, what the heart will pump. Okay, hemorrhage and blood transfusion. I don't know, it is either a 10 marker or 5 marker for Charlotte. Okay, all these questions are discussed. There's nothing for me to discuss here, but in and out is required. I know this was the not so important topic in your blood transfusion part of pathology, but in and out is required in general surgery. Okay, what is reactionary hemorrhage? If after surgery within 24 hours, if the patient starts to bleed, then it is called as reactionary hemorrhage. What are the causes? These are the major causes. Okay, this very important cause. Okay, these are the local symptoms. Then what is secondary hemorrhage? After 24 hours, but within 7 to 14 days. If it happens, then it's secondary hemorrhage. Okay, this is how you manage it. Okay, what is auto transfusion? When patient will come and take back when he donates his own blood, and after surgery when he take back his own blood, it is called as auto transfusion. Okay, and what is massive blood transfusion? Definition is very important, where you do a replacement of transfusion of blood equivalent to patient's volume within 24 hours. What is patient blood volume? That is 4 to 5 liters. So if you do it within 24 hours, then for that particular age, then it is called as massive blood transfusion. What are the major thing which are worried? Hypocal and hyperkalemia. Hypocal because of citrate which is present in your blood bag, and hyperkalemia because of your destruction. And again, what important thing which you need to monitor about DIC, that is coagulopathy. Okay, indication where and all you give, I think you can just go through that part. Then what is artificial blood? If you have any substitute for artificial blood, then it is called as either you can have RBC का substitute or you can have platelets का substitute, correct? So RBC का substitute are perfluorocarbon and stroma free blood hemoglobin. I have not seen this, I have just studied in book, it might be true. Then what about the plasma का thing? You have human albumin and dextran. Okay, and what is damage control resuscitation? it is the more aggressive correction of your coagulopathy. Because what is happening here, you might give your blood, but what about the coagulating factors which will get diluted? So uh, how do you correct that? So what are the principle of that? It is okay to have permissive hypotension than having full volume and early balanced blood transfusion. How do you do that? You give PRBC and plasma and platelets in the ratio of 1:1:1, so that even you have coagulating factors. Okay, then minimal crystalloid use, so that there is no dilution, and early correction of coagulopathy if seen, because once he goes into coagulopathy then it's difficult to treat. So how do you correct the how do you prevent coagulation to occur? By allowing permissive hypotension, because it is easy to manage hypotension than DIC. So with that, how do you manage it is something to do with damage control resuscitation, which was as per 3 marker. Okay, then blood transfusion, again this is some definition which you need to know. Then again, while writing indication, mention about the components. Okay, what are the components which you have know of? Whole blood you can give, or only RBC you can give, or only platelets you can give, or only plasma you can give, only cryo you can give in VBD and hemophilia. Mention that, then divide it, then you write the causes. I am sure you know all the disease, you know platelet disease, you know all the disease which is actually important. Then again, where do you give the whole blood? So again, where do you give your whole blood? Whenever you are doing an active massive blood loss, whenever there is a blood loss or in the hemorrhagic shock. But make sure you remember about damage control resuscitation. Okay. Then again, while writing complication, you have to write major things which you need to mention about. This is the most common, but you have to write about Trally and Taco. And also this is something which you need to mention, that is infectious. That is, you have to write about all your HIV, then malaria, all the 7 things which is there, you have to mention about them. Then this is also important complication, but importantly you have to mention about all these things. That means whenever you do a transfusion, you might have a febrile non-hemolytic reaction. That means the patient will get fever, but it is not, but there will be no hemolysis. Or you might have a hemolytic transfusion reaction, or you might have a reaction where it will go and affect your lung, or you might have a reaction where it might cause cerebral edema, or it might cause sepsis. But in delayed condition, what happens is that you might have infection or all the other conditions. Then again, to do with electrolyte and nutrition is an important 5 marker, though TPN is already asked for 3 marker. But again, electrolyte related things I have already discussed in medicine. So this hyperkalemia and hypokalemia is something which is important. This I have discussed in that part. The major thing which you need to discuss here about is about a refeeding syndrome and total parenteral nutrition. How do you administer that? So firstly, what is how do you take what are the possible ways of taking nutrition? Either you can take enterally or parenterally. So what does enterally means? It's through gut. So what does parenterally means? Either IV or IM, all those things. So again, in TPN, what are the things where you can give? Either you can give central line or you can give peripherally. So when all the nutrition requirements, so this is something which is important. Okay, when all your nutritional requirements are given through IV route and not through GI. What does enteric mean? Something to do with GI. Correct, is known as TPN when it's not through GI but through IV route. Okay, again, these are the 2 types which I am sure you would have seen. Then again, what are the indication you need to know each and everything. But remember, for 5, since it's a 5 marker, remember 5 indication, but 5 broad indication, and again subtopics. Okay, whenever you cannot give proper enteral nutrition, when you cannot use GI tract, when, so basically you think about anatomy, when anatomy is not there, or when physiology is not working, or when both of it has collapsed. Okay, what do you mean by non-functioning GI tract? Physiology is not working. When what do you think about anatomy is not working when surgically you are doing something? For example, you might have peritonitis or all those things. Okay, you cannot use GI tract at that time. When you cannot give enteral nutrition because of the patient is morbidly ill, these are the other conditions. So think like that and present TPN. So what are the goals of TPN? You need to provide nutrition and metabolic requirement, and also you have to provide you have to reduce the catabolism, and you have to provide wound healing. This is the main thing. I think you can remember this. For if you want, you can remember NMC for this, because in and out of TPN is required. So what are the components which are involved? Again, all your macro and micro nutrients are involved. Macro are carbohydrates, amino acid, fats. Then micro are your vitamin, electrolytes, and trace elements. And what is the complication? Most important thing, it can be either biochemical, because you are giving major thing you have to mention is about the biochemical complication, which might be, again, whenever what biochemical complications comes to your mind, what you have to write about electrolyte, and also about your all this osmolarity thing, then any hyperglycemia, hyperosmolarity, and also pre-renal azotemia. Then what are the other complications? Again, because of the injections site, you might have dermatitis. The technical problems, you might also cause superficial thrombophlebitis, air embolism, though it is rare, and also it can cause pneumothorax. The main thing which I want you to remember is biochemical. Okay, this you can remember as BOT. Okay, why I'm making mnemonics for this thing is because I'm sure something related to this will come. Okay, then burns. Yeah, man. Important topic. I cannot say how important it is, but it's very important. Though you have learned this part in your forensic medicine. So see, that's what I'm saying. If your foundation of your first year, second year, and third year is right, fourth year is like cakewalk. You have to just fit it into place. You just need to add some extra things, something related to surgical topic or something related to management, and you are done. Okay, so let's come back to the burns part of it. So again, these are the classification which is there depending on the thickness of skin involved. This is one of the classification which is being mentioned. Again, I'm sure you would have learned this. Again, the Wallace rule. Again, you have to divide it. Again, make sure the rule of 9 plus 1 in the perineum. And again, here, what is the major important thing? Because head has more surface area, so you give 18 here, but here it is reduced to 13.5. Okay, nothing extra here. Make sure, because it's a concept of pediatrics, not some concept of surgery here. Okay, then pathophysiology. If they ask for 10 markers, you write. Otherwise, you need not write, man. Then management of burns. Again, first aid. What? Stop the burning process. The major thing in burns patient, what if it's a combustible burns patient, what is the major thing how patient will die? Because of carbon monoxide poisoning. So you need to manage about that also. So again, you have to do the first aid part of it. And again, ABC, assess percentage of burn based on the Wallace rule. And again, you have to give sedation and proper analgesic. It's empirical to use all your morphine and all the analgesic, high-end analgesic at this case. Again, local management, you have to talk about dressings at regular interval, whether it's open or closed, and also you have to exercise the love, and you have to do proper antibiotic coverage. Again, how do you do the fluid resuscitation? You have to mention about this Parkland regimen, where you will give 4 ml percent per kg body weight in 24 hours. Okay, then again, how do you give it is given here. If you want, you can just mention about that also. And electrical burns, again, you have two types. Again, you have low voltage burns or high voltage burn. Again, you will have, what is the major clinical feature? You will have entry wounds as well as exit wounds. Again, but what is the major problem here? It's a deep muscle. So what is the major cause of that? Cardiac. Okay, then acid injuries, nothing extra I have to say, the same thing. Okay, this is one important thing. And also analgesia, don't give alkali, because it's an exothermic reaction. Okay, what about the post burn sequelae? It was as for 3 marker. You can have local thing or functional thing and general thing. Then ulcer, trophic ulcer. So I'm sure from second year you are seeing this in all your surgery rounds, so I don't think I need to explain anything about this in and out you are seeing. And also important thing is leprosy. Whenever you see, what you see, screen for diabetes. If there is diabetes, then you have to control sugar. Then again, you have to address about regular dressing and debridement. If infection is present, treat it, and surgically if you want, excision, and followed by a skin grafting. Okay, sinus and fistula, though these are not as, I think, potential 3 marker or 5 marker questions can come. So go through competency once again while going through this topic. Okay, swelling, 3 marker, man. Okay, what if they will ask you in 3 marker is about the transillumination swelling, what are the swellings which are transillumination, or about ganglion cysts which I discussed in author recently, that they can ask, and all these things they can ask. Again, the same things whenever you discuss about swelling, again you can do the same clinical feature, swelling, then associated with pain or not, all these things. Then whether any neurovascular involvement. Okay. Then again on examination you have to write about the transillumination test. Okay. Again, nothing I have to say. The same thing. Okay. This is an important 3 marker. How do you write examples of transillumination swelling? Divided into congenital, acquired, and cystic. Okay. Again, what are the things which are there in hydrocele and meningocele as in congenital condition, in ranula in acquired condition, in cystic hygroma or ganglion cyst. Okay. Sebaceous cyst, it's due to blockage of ducts of sebaceous gland. Again, it's a painless swelling. Okay, these are the complications. Because I've explained it there, I'm not talking but mention about this and this. Okay, ganglion cyst I've discussed in ortho, I'm not discussing it. Then hand and foot, again the same thing I discussed this part in ortho. Same thing. Okay, if there is abscess, drain it and then start on antibiotic. If not, then you can directly start on antibiotic. Then again you have to elevate the hand because it reduces the edema, because it's a closed compartment. Okay, so you have to prevent all the compartments involvement, all those things. What is phelon? Phelon is what? When you have the same thing in your finger, that is acute paronychia kind of thing is phelon. Okay, again the same thing to look for osteomyelitis. This complication ka part you have to write. Again, neoplasm, tumor markers. I like the way he has classified as tumor markers. So make sure you write the same thing if it's as in medicine, general medicine, or any other topics. Okay. Again, it can be divided into category 1, 2, 3, 4. One is hormonal. If you feel it's difficult to remember, make sure you remember calcitonin and VMA. Okay. In pheochromocytoma. These two, I'm sure you can remember. This also in OBG knowledge you can remember, man. Then what about isoenzyme? PSA you remember. Then what about oncofetal antigen? AFP you remember. How AFP is there? I have explained in one of the video. You can go and watch it for sure. Then what about the mucin? CA125 and carcinoembryonic 1997. So make a mnemonic here itself. I home. Okay. So because it's a classification, so you need to place it in the same order, though this doesn't have any significance to know as why one after other, but to remember on the day of exam, just to write for 3 marker and come, I'll just do one mark. Okay. Biopsy, again you might this is the important surgical topic. Again you can have either do a closed biopsy or an open biopsy. Open biopsy is either incisional biopsy or an excisional biopsy, where you remove everything. Again in closed, either you can do needle biopsy or punch biopsy. Okay, there is nothing more to explain in that case, so I'm not explaining that part. Again, what are the 3 pre-malignant lesions of skin lesion? Again, you have to divide it like keratinocytic or pigmented or melanocytic or genodermatose. Then explain it. Then about the malignant melanoma, this is like important 5 marker. Okay, malignant melanoma they can ask for 5 marker or 3 marker. The same thing which I had studied. Clinical feature also, while writing clinical features, mention about the local features, general features, then due to lymph node involvement, then due to metastasis, and systemic features. Again, mention about Barslow's classification. You have to do 4 classification under it. So what does he say? He say it's based on skin involvement. Okay, if it's less than 0.75, it's stage 1. From 0.75 to 1.5, it's stage 2. Then 1.5 to 4, it is stage 3. Then more than 4, it is stage 4. Okay. Again, you have Glasgow criteria. Again, the ABCD mnemonic, I'm sure everybody know. So make sure you write that also. Okay. So this is the TNM staging. This is the 8 AJCC TNM staging, which I'm sure you can just before that you study this part. M0 is no metastasis, M1 is there is metastasis, N is N1, N2, N3. So if there is 1 node or 2 to 3 node or more than 4 nodes, and in T it is based on the thickness. Okay, not the tumor size, it's with thickness. If it's associated with ulceration, then it's B. If it's without ulceration, then it is A. Then based on 1, 2, 3, 4 is based on the depth of involvement. 1, 2, more than 4. Then again I have discussed the same thing, just try to put it into a picture. What is the treatment goals? You have to completely remove the primary tumor, you have to prevent recurrence, and you have to give a quality life. Okay, for which you will do extensional lymph. And to prevent a micro metastasis, obviously you give chemotherapy or immunotherapy. How do you do the local execution? You have to mention about handless wide local execution. Prognosis also you can write if it's a for a 10 marker or a 5 marker question. Then basal cell carcinoma, what is it? It's a locally aggressive tumor. Okay. So these are the types. So majorly we'll talk about ulcerative types. Though basosquamous, pigmented, cystic, nodular are there. These are the clinico-pathological types. Only you can see superficial, morphic or fibroepithelium. Again, the same your clinical feature focuses on local things. Don't write in general and fever and weight loss. Though it's not seen at the later stage, it might be seen. But this is the main thing. Don't write about metastasis also. Again, diagnosis is just by wedge biopsy and treatment is by incision. Exercise is then you need whatever tissues are left, you have to do a graft. What is Marjolin ulcer? When long-standing ulcer, if it's not treated and not managed properly, it will go into a Marjolin ulcer, which is the differentiated squamous cell carcinoma. These are the etiology. Then how do you treat it? You have to completely do wide local excision, or if it's involving majority of it, and you have to go to amputation. Then you have to go with adjuvant radiotherapy. Soft tissue tumor and sarcoma, yesterday only I discussed in medicine. Majorly it's about the Kaposi sarcoma thing. Again, the same thing which I had written, I have just written. Amputation, though here also there are no questions which is asked. Make sure you study from ortho, or even ortho doesn't have any major question. Okay, reconstruction, important 3 marker question in nowadays. Okay, I think these flaps are expected in this paper or next 2 years ka paper, though there are not many things which is there. So study this topic very properly. Okay, so what are the major things? You have to study about skin graft and split skin graft. Okay, which is also called by Thiersch's graft. So okay, now let me talk about skin graft now. So when you are grafting the whole skin, then it's called full thickness graft, where you will graft both epidermis and dermis, which is called as wolf graft. But if you are grafting only a part of epidermis, full of the dermis and part of epidermis, full of epidermis and part of dermis, then it is called as partial thickness skin graft. Okay, then you have to know the indications also. If it's a well granulated ulcer, obviously it will heal. No, so you just need to support it. And if it's a clean wound, then after surgery you go with partial thickness skin graft. Then transplantation. Again, let me clarify. Please study this topic from competency based, because an expected 3 marker is there from this chapter. Again, transplantation, either a 5 marker or a 3 marker question is like sure in this. Again, the principles of organ transplantation, though it's a debatable topic, though it's a outcome based topic, this is an important thing. So what are the principles? Again, you have to mention about all these things. Okay. You have to select the donor, you have to match the compatibility, then you must be willing for long-term follow-up. Then what do so divided into what does it mean? So before organ transplant, this is during organ transplant, and planning for organ transplant, then this is after organ transplant. So you can make a broader classification only, then you can mention. So make sure you mention about this. And nothing to explain, I have simplified it further so that you don't miss on it. What is the immunological basis of transplantation? Again, it's antigen which is most important. Either you have MHC or minor HLA types, and also this is the main thing also. Then rejection, hyperacute, acute, and chronic. Okay, this again I want you to specifically learn. Okay, then this is something to do with general surgery. Okay, till now we have discussed only general surgery part of it. So what are the major important things which we study? So now let me just go through this part. So general surgery is done. Okay, now you should feel satisfaction of what I have studied also, no? So I just made that. Okay, then coming to facial anomalies. So though this is a super specialty topic, to be very honest, just learn about this. Then this write about the surgical treatment ka plan, when will you start doing it? It is more than enough. What is amyloblastoma? It's also a dental topic is what I feel, so they don't concentrate it much. So you just need to know, oh, these are the conditions which can be there. Okay, again, Since the jaw, you will have facial asymmetry. It's a locally aggressive tumor from the epithelium involved in the dental epithelium. That is what is the main thing. Okay. Then again, these are the differential, and there is something called as OPT, which is done in this. So even in that, you will get unequal appearance. Okay. This dentigerous cyst. Again, it's a unilocular cystic swelling arising in relation to dental epithelium. Something related to this only. Okay. Again, OPT, you will find the tooth within the cyst. Again, what is UPLS? It's a reactive growth arising from the mucoperiosteum of your gums. Again, it might be congenital, fibrous, or during pregnancy also it is common. Then what is the treatment? Local excision. Okay, till the periosteum, then removal of any irritants. This is the major thing which you need to address. Again, cleft lip and cleft palate. This is not the important question as such, but they can expect. You can expect because the paper itself is unpredictable. This is the classification. First, you might have just only the lip which might be getting inward either unilaterally or bilaterally. Then you can have the palate which is getting inward either complete or incomplete. Then you might have the secondary palate which is getting inward, the soft palate kind of things. And again you might have both primary palate and secondary palate. Then again you might have both cleft lip, cleft palate, and everything together. Okay, divide, and then first is only lip, then primary palate, then secondary palate, then both primary and secondary, then both all. That is all. Okay, major thing is Millard criteria. So when will you operate in a patient of cleft lip, the patient should have 10% pound 10 pound ka weight, then 10 gram ka hemoglobin ka cut off more than 10, and it should be 10 weeks old. Okay, then you have to how do you do that? Again, you have to rotate the local nasolabial force, then you have to manage the associated primary secondary lip. Then these two things you write, man, more than enough. Then again, what will you do with the cleft palate? You have to go for, if fails, then obviously repair is done at 12 to 18 months. Okay. Then the oral cavity, that's it about facial anomalies. Nothing much. You study about these things, it should be more than enough. Okay. I don't expect you to go and study the competency based thing for this part. Oral cavity, yeah, all these things which I studied in your pathology itself, but this is something which I would like you to go and see. Okay, pre-malignant region again divided into iris, medium iris, and equivocal breaks. Again, leukoplakia, erythroplakia, and for submucous fibrosis and local lycoplanus and DLD. Okay, mentioned about that. This leukoplakia, I don't know how many times I studied in pathology, so I'm not explaining that. But treatment part, you have to rule out carcinoma. This is the major important thing. Okay, then again, prevention. If it's present, go with isoniazid and beta carotene. Though nothing is useful, at the end you have to go with laser excision. Again, ranula, what do you study? It is a transluminant swelling, acquired transluminant swelling. Okay, it is an extravasation cyst of sublingual gland. Which gland? Sublingual gland. Okay, what is plunging ranula? When it extends into the submandibular region through the deeper part of posterior margin of mylohyoid muscle. It's called plunging ranula because it's bimanually palpable also. Then what are the differential for tongue ulcer? Make sure you write it. It might be traumatic or non-traumatic. In non-traumatic, start with infective, then start with after ulcer, then it might be pre-malignant or malignancy in case of tongue cancer. So divide and then write. Okay, then carcinoma buccal mucosa. I'm not sure with two things. Okay, whether CA buccal mucosa is like sure 5 marker, though it's very common. I have not expected you. I have not seen papers where they have asked in RS4. Okay, they have asked as management like a 10 marker thing. So just go with the major things. And because the treatment and the TNM staging itself is very complex, if you ask me to be very honest, this thing, and also in ENT, the larynx carcinoma part, those are those places where I feel I still need to study a lot because I feel kind of confused. Okay, so those two parts I am please refer other books because I don't think I am the best person to explain you that management, but all these notes I can provide. Okay, these are the risk factor clinical feature. Whenever you are writing, again divide into local and systemic. Again, systemic, what will you write? General, what will you write? Fever, weight loss, anorexia. Then again, local feature, I'm sure in and out, and again, whenever there is a cancer, obviously you need to write about the lymph node involvement, and also what are the different things, what are the other clinical features which you will apply. That is about the difficulty in swallowing your exam. Not at all important. Even if it's as for 10 markers, I know you can make up a time, right? Do investigation again to diagnose. You have to take a wedge biopsy and FNAC of the lymph node. To stage the disease, you need to do all these things. And also, what is the major stage of treatment is surgical with chemoradiation. Okay. Again, principles of that, you have to select your patient, because if it's a stage 4, there's no point in doing surgery and giving a morbid life. If it's a primary or a secondary thing, again you have to do the surgery, then you have to plan for reconstruction with the plastic surgery, and you have to know which free flap you are using, whether it's free fibular flap or any other flap. Then it's the multidisciplinary care. Your medical onco will come, surgical onco will come, pathologist will come, something called as tumor board. All these people has to come and decide how to plan the overall treatment of this oral cancer. That is the severity of the disease, which could be stopped by just stopping tobacco. Okay, just wanted to say, because something it's very difficult, man. So this is the tier I'm staging. I've just written because I'm I'm not capable of explaining this. Okay, let me be very honest. You can just refer other part, or you can just see other video. What is tongue tie? It's a short, thick, fibrous thing which is there in the frenum linguae. Okay, these are the clinical features. You can just exercise and throw it off. Again, carcinoma thing, the same thing. Again, types I've written. Again, the clinical feature. Again, you can divide it into general and systemic. Again, in systemic, you have to write about local and due to lymph node and due to metastasis, and if any associated with. What is the local thing here? Ulcer, lymph node, submandibular lymph node involvement. Then again it might grow. Again, lungs or any associated dysphagia. So again, in general, cachexia, all those things. Investigation, again to stage the disease, and to confirm diagnosis you go with histopathological examination. Then again, to plan for management you go with CTM, right? Then what is the treatment part? These are the options you have: surgery, chemo, radio, immunotherapy, all these things. But what is the major stage? If stage 1, then surgery. Stage 2 to 3, again either you can go with concurrent NSCT-RT plus surgery. But if stage 4, better to go with palliative chemo. Any concepts of oncology, if you are feeling difficult, I made a video for that as well in the oncology part of the playlist in the above YouTube channel. You can just watch it. Okay. Then again, neck part. Okay. Again, TB lymphadenitis is something which is important. Though these are asked, but cord abscess is something which is most important. What is the first thing which we are going to discuss here is about the bronchial cyst. Okay, it's an epithelial cyst. It's a congenital epithelial cyst. Okay, which is arising from the remnants of branchial apparatus in the second branchial cleft. The same thing, clinical feature. If it's a swelling, what are the things which you'll mention? You have to mention that word, whether it's painful or painless, whether it's slow glowing or fast glowing, and where is the swelling. It's a lateral swelling because it's about the development, it's about the embryology. So soft fluctuant pulsatile swelling because carotid artery is there. Again, ultrasound. Again, if you do a biopsy, be careful. You have to mention about the cholesterol testing. Okay, complication, all these things, infection, all these things. Again, differential, and obviously have to exercise it. Cystic hygroma, again, is a cystic swelling due to sequestration of your jugular lymph sac from lymphatic system. Again, the same thing. Okay, I'm not explaining it. Again, whenever you see swelling, write about infection, secondary bacterial infection, treat with antibiotics. Okay, in and out you can write. So the major things which are there's nothing here to explain, so I'm not explaining. Again, CBT is an important topic here. While mentioning about that, it mentioned about the slow glowingness of it, painless lateral expelling part of it, and also syncope part of it, because it is pressing what? Vagus. So it can go in a vagal syncope. Again, on examination, you have to talk about the Fontaine sign, which is positive, and again, Lyme sign, which you see in angio. Okay. These are your differential. Again, if it's a small exercise, but if it's a large, you have to exercise and put a vascular graft, because the major artery which is going there is there. So you have to do that also. Again, salivary gland, in and out. Okay, you have to know. This is the 2017 WHO classification of salivary gland neoplasm. It might be a malignant part, or it's a benign part, or it's involving soft tissue or hematolymphoid or secondary tumors. So malignant part, first to study about benign part, this pleomorphic adenoma, Warthin's tumor, and oncocytoma, also ductal papilloma. Then you convert this into malignant, that is metastatic pleomorphic adenoma, or mucoepidermoid carcinoma, or acinic cell carcinoma. Soft tissue, obviously hemangioma. Then all these are hematolymphoid, that is Hodgkin lymphoma or DLBCL, or all these things you can just diffuse large cell B cell lymphoma. Same clinical feature, same thing you can just mention. I'm not touching upon that because in and out, because I've explained you the template. Fit it into the place and just okay. Don't nothing much, nothing less. Okay, these are the things which you do for this. Then again, mainstay is surgical, so you have to remove the, if you remove the superficial lobe, then it is called superficial parotidectomy. But if you are removing the both lobe, then it's total conservative parotidectomy is also done by but you are retaining the nerves. Okay, these are the complications of surgery. Whenever you're writing surgery, you have to write about intra-op, post-op, again divided into early and late. Obviously, in intra-op, the major thing is about hemorrhage and the nerve injuries. And early, again, all these things. Hematoma has to be mentioned, that is nothing but secondary hemorrhage. Again, you might have infection, leak and fistula because you are repairing the gland, and also you might have damaged the facial nerve. Again, late is something, this is something which is very important. Okay. And what is phrase syndrome? Again, there is a definition. I'm sure in anatomy you have studied it. Whenever you eat, if you sweat, it is called as phrase. This is the diagnostic criteria. Again, if it's very, very severe, then you need to go with surgical part. Then, okay, thyroid part. In and out, we have studied in medicine on how to manage thyrotoxicosis, thyroid storm. Only part I am discussing here is cyst and complication of thyroidectomy. Okay. What is about the cyst which we are talking about? It's about the thyroglossal cyst. It's a congenital midline neck swelling. Okay, though it's present, they present you after the later part, that is on 30-40 years of age. This is a swelling in the midline which moves with protrusion of tongue. All these things you need to mention. Okay, you have to rule out malignancy because PCT is very common. That is papillary carcinoma of thyroid. Okay, you need to rule out that part also. And major thing which I would look for is cyst trunks operation. You have to remove the cyst, and also you have to till the foramen and fulcrum, and also remove the part of iod bone where it is involved. Major thing. Okay, that's it about thyroid. Then thyroid neoplasms, I think I have already discussed this. Okay. Now again you can just mention, again it can be just benign or malignant part. In malignant, again it can be differentiated, undifferentiated, or medicinally, or malignant lymphoma, and also you can have secondaries as well. Then this is the etiology part which I sure you know it. Again you might have chromosomal rearrangement in case of BRAF and all those things, and radiation, either external or internal radiation, and all these features also you can just mention. Same clinical features and also compressive symptoms is something which you need to talk about, and also AMIS criteria for the prognosis of it. The age is less than 40, and if there are distant met, and also if there is extension of primary tumor, and if the size is enlarged, then it indicates a poor prognosis. Though neoplasm is a major surgical topic, at the end stage you have to cure by chemo radiation, and papillary carcinoma thyroid is one of the good, one of the best cancers to have. I think the Bailey or some of the good books states that in every cancer, the surgeon will visit the death ceremony of the patient, but only in the papillary carcinoma of thyroid, the patient will attend the death ceremony of surgeon, something like that. So it's one of the good cancer because it's a differential. But even at the later stage, you cannot do anything. Just for making statements and quote, I think that was me. But yeah, it's a true. It has one of the good prognosis of in surgery. Okay, and this is the major thing. In and out, I'm sure you know. But the major thing which I would say is for 5 marker or 3 markers is complication. Okay, again, what I told, whenever you're talking about the removal of gland, you have to talk about immediate, early, and late. Again, basically you can talk about intra-op and post-op. Again, in post-op, you can write about early and late, which I discussed in the same. What happens in intra-op? Either you can have hemorrhage or respiratory obstruction due to hematoma and thyroid storm if you have not prepared adequately. So I discussed in medicine, IV fluids is the major thing, and you have to maintain the fluid level, and also you have to start potassium hydrate 10 days before surgery. Okay. Then what are the early complications? Either you can have RLN palsy or ELN palsy, and also wound infection, and also major thing, if you remove the parathyroid and if you have not replaced it, you can have hypocalcemia, hypocalcemic tetany. And also what are the late complications which you can expect? Obviously hypothyroid, that is something which you should know. Then also you can have vocal cord palsy, and also you can have hypertrophic scoliosis keloid. Make sure in and out you are studying, because this is like a short question. How do you write about the complication of thyroid? Intra-op and post-op. Intra-op, you have to talk about the hemorrhage part part of it, then injury to any nerve part of it. Then also have to talk about the thyroid storm if you are not prepared in for properly. Then again in post-op, what will you talk? Early and late post-op. And early, again you can talk about the reactionary hemorrhage, nerve injuries, and also about the infections which can develop, and also the palsies, and also the biochemical abnormalities like hypocalcemia. Then late, obviously about you can talk about the hypothyroidism part, vocal cord palsy part of it, and keloid also. What about the thyroid storm? In and out, in and out. I have discussed. I am not talking anything about it. It's some scoring which they use, but it's a clinical diagnosis. I am not at all talking about this because I have already talked. Okay, in and out. I have talked in your medicine part of it. Please go and watch it because already I'm sure many would have watched it and have come. So there's nothing much to discuss here. Okay, the notes is anyway there in the description box. You can just go and see it. Again, goiter. This is the classification. So goiter is nothing but enlargement of the thyroid gland. Also, it can be either due to toxic things or non-toxic things. Even in puberty and pregnancy, it's common. Again, iodine deficiency, it's common. In all this neoplastic condition, it's common. Even in deconens and Hashimoto's, it can be seen. But don't mention about all these things. This is also very rare. These three things you mentioned. Okay. And parathyroid and adrenal, in and out. First thing about the tetany, that is due to hypocal. From physiology, I'm sure you are studying it. These are the causes. Obviously, now the same thing which we discussed. These two things, I'm sure you will know, and because of these things also you will know. Again, what is the clinical feature? Though many are asymptomatic, but if it's a severe hypocal, you will have circumoral paresthesia and twitching, and also stridor. This is the major things why patient will die. Obviously, chopsticks and trousers in and out. You had studied in physiology. It was a 5-mark question there. And also, what are the investigation again? You have to do calcium levels, parathyroid hormone levels. Again, after stabilization, you have to look for the cause for that for which you will do urinary calcium and malignancy screening also. Okay. This is for what? This you are suspecting hypercal. Okay, not yet. I'm sorry. Okay. Then again, treatment. I'm sure you know about it. You have to give calcium gluconate. Okay. Men's syndromes. Okay, I'll talk about men's syndromes. I think it's a okay. Pheochromocytoma. Clinical feature again. Your general and systemic. Again in systemic, you have to talk about severe headache, severe SRS, all those things. Again, these are the things which you need to mention. These are the differential. Again, you diagnose with this. Then also about the ultrasound abdomen which you need to talk. Okay. Then again, how do you do the treatment? First you have to start them on alpha blockers, then you need to start them on beta blockers. Then in the operative period, you have to keep infusing sodium nitroprusside. Then obviously if nothing happens, you have to plan for an adrenalectomy. So men's syndromes, in and out is important. So for that, the history part of men's syndrome is something which I would like to share with you, because everybody will just by heart and go the men's syndrome, that is men 1 equals PPP. What nonsense is that, man? Go and study the history part. So interesting it is. So what happened was for the men's syndrome part was firstly when people used to get the most common presentation of men 1 is parathyroid adenoma. So people who had operation of parathyroid adenoma, no, after that they used to have even pituitary tumor, then pancreatic tumor, all those things. So what happened with the late in the first part of the diseases, many of the people never used to understand why they used to have recurrent endocrine neoplasia kind of thing. So what they did was they started doing the statistical part of it. So they started seeing what are the incidences of all this, whether they analyzed whether there is any correlation. So what they found out was, see, that's what men to A. Okay, 1 second. Men to A, men to B have almost same thing. That is medullary carcinoma, pheochromocytoma, and PTH. But here you have mucosal neuroma singly. So what they did was they thought it's something to do with when did this men's syndrome started coming is in the genetic era. So first they had classified as men 2A and men 3, but later they found out that these two almost has the same, that is one is red gene and one more is other gene. Okay, but what happens in parathyroid whenever the patient comes to with parathyroid, now it's your duty to screen them for this and this. Okay, what is multiple endocrine neoplasia? That means if there is an endocrine organ which is under neoplastic, then you have to screen for that also. Then what is the importance of learning pheochromocytoma after MEN syndrome? That is, whenever you get a patient of, whenever you are operating on a patient of medullary carcinoma of thyroid, anesthesia people will never give you clearance without screening them for PCM. Very important, very important, because in both you have pheochromocytoma. So that's how the era has evolved. Okay, again you have men 4 men 5 which is coming out. There's something called as meon also, that is whenever there is a endocrine neoplasia which, if it's there, then you have to suspect even other the whether non-endocrine neoplasia, which is a new topic and not an exam predominant topic, just to make surgery interesting. I told about this. So whenever you're stuck with symptoms, make sure you visit your history back and know what are the mistakes they do. Okay, then coming to the parathyroid adenoma part, again it's due to parathyroid gland. Again these are the same thing because of hypocal. Okay, you need to mention about that. Again you have to mention about sestamibis scan. Also you have to screen for men syndrome, that is men 1. Mention, please mention about it. Again treatment is to do parathyroid remote. Okay, then breast, again an important 10 marker bar 5 marker. Again a CBQ based on breast cancer will be asked, or these are the 5 markers which is expected. So CBQ, whenever it comes, make sure you write about the clinical feature. And treatment part, I'm sure you will write about all these things, that is surgery, then radiotherapy or chemotherapy. In first stage you will go with surgery, and these are the things. Okay, or what about in a fibroadenoma thing? Again these are the types which you have. Again here it's a painless swelling, it's called as it is called as mouse breast because it moves around the breast. Okay, this is solitary in nature. Okay, again if it's small, follow up. If it's large, then you can do excision via circumareolar incision. That means you will do an incision around the nipple. What about in fillers? These are the parts. Again you will do either a benign, intermediate or malignant. But what is the major stage? That is simple mastectomy. Whenever you, by seeing the size, you might think it's a radical mastectomy. No, it's a simple mastectomy. Okay, again if you are suspecting for rule out meds, you have to do a chest x-ray. Okay, you have to do a white localization. It's simple mastectomy. And what is antibioma? If there is intramammary mastitis and it's not drained, the antibiotics will form a layer. Okay, you think it's an abscess, then an antibiotic will form a layer. So based on at this part, now it cannot enter, the antibiotic cannot enter. So what I have to do, I have to excise the whole part. This is nothing but antibioma. You can just treat so that you get a clear picture. This ductectasia, it's a benign breast condition characterized both of the things, that is whenever both ductal and interductal part is involved, and it's at the superior latex, it's called as ductectasia. Major important thing is you have to mention about sticky part. This is that the close differential for carcinoma breast. You have to talk about all this. Cloxacillin is the talk of choice. Anti is like a very important thing based on your breast evolution. This is nothing but physiology which they are talking about. If you just mention about it, that's more than enough. Okay, major thing everywhere you have to rule out malignancy. Causes of malignancy, gynecomastia I discussed in medicine. Make sure you read about that. Nothing else, nothing more. Okay, then again the clinical feature also I have discussed. Nothing, I'm not discussing any part. But if it's a surgical excision, here major thing which I would like to say is, if it's a localized part, then you go with the circumareolar incision. But if it's a large diffuse part, then you have to go with Goliath-Dormer submammary incision for excision. Okay, then also you have to do all these things. And breast cancer in and out. Okay, I am not talking about many things here because same things. Again, general factors is something which you have missed. Okay, make sure to mention TNM staging. It's easy. This TNM staging in and out is because it's very common. Okay, and it's there. It's not like oral cancer or larynx. It's very easy. First, take a cutoff for 2 to 5. If it's less than 2, then it's T1. 2 to 5 is T2. More than 5 is T3. Okay, N1, N2, N3. So for example, if it's an ipsilateral, mobile node, it's N1. It's fixed and matted, then it's N2. Both side, it's N3. Okay. Then T4 is fixed just one involvement. Then B is skin retraction. The C is A plus B. D is inflammatory carcinoma. Okay. Then molecular subtypes, if you want, you can write based on your hormonal positivity, ER positive or PR positive. Here the hormonal positive is there, but HER2 is negative. Luminal B is all three positive. HER2 rich is ER negative, only HER2 is positive, but basal cell is triple negative. This is as one of the worst prognosis because of its recurrence, but cure melts with chemotherapy. Okay. Investigation again to do the same thing. I have told you the template of how to go with the investigation, so I'm not discussing much. So but it's an important 10 marker. Make sure you study in and out of it, and then okay. Treatment protocols, these are the aims. Where will you go for toilet mastectomy in inflammatory breast cancer or final, that is T4. So it is the T4D is itself inflammatory, but if it is a palliative chemotherapy, then you go with toilet mastectomy. Okay. These are the major things which you need to talk about. In prognosis, you need to talk and follow up also. Breast cancer in and out you have to study. I know I have not explained much of it, but there's nothing for me to explain. Make sure you know the TNM staging very well, and then go with the molecular subtyping. Though this is the main, this is not given in your books, but this is the main thing which we follow. Okay, whether it's luminal A, B, or HER2, which are basic. So based on that, then you based on your hormonal positivity, then you divide the molecular subtypes. Then if it's a ERPR positive tumor, then obviously you give it blockers. Then again, if it's HER2 rich positive, then you can give trastuzumab. Okay, so all those things will depends on that. So I'm not discussing that part. Then again, minimal invasive surgery, only 2 questions which is being asked, and I think it's one of the sure question even for your exams. Advantages and disadvantages. Make sure you classify in whether it's a patient related advantage, surgical related advantage, and wound related advantage, and mention the same thing. Okay. It might be, there's nothing here to explain, so I'm not explaining anything. And also, what about the surgeon related what are the disadvantages? It's a steep learning curve, and also you don't have the tactile feedback. And also equipment related is cost and dependence, and also patient related is they might have more additions, and due to pneumoperitoneum there might be increased intra-abdominal pressure or decreased venous return. You can just remember PES for subhead. Okay. Then what are the principles of laparoscopy? That means they are asking you how do you create laparoscopy. First you have to create pneumoperitoneum by inflating through carbon dioxide. Either you can do open or close. Or for closed you use where is needed. Then how do you place the ports? That is what is something which is you have seen in your surgery thing. You have to do a triangulation principle, though primary port is kept in umbilicus. Then how do you visualize? By camera and light. Okay. Then instrumentation and tissue handling, you have to do gentle tissue handling with precise dissection. And you have to maintain always you have to monitor the BPI and all these things. And also ergonomics and surgical positioning is something which is important. Research related, one question that I asked, so I just mentioned it. So make sure you draw a triangle. Then this is something which is very part, that is first to start with case report. Then analytical, you have case control and cohort, which are studied in your for community medicine part. This is also you are studying in community medicine part. And this is something which is done. Based on this, the government officials will take up systematic review or meta-analysis. Then they form principles or health decisions based on your meta-analysis. So after case report, case series comes. That is, case series is mix of case reports, 4 to 5 case reports. Mix of orders is either case control or cohort study. Sorry, is either a case control or a cohort study based on whether it's a cross-section or a surveillance study. RCT, non-RCT is done on the population. This is also done on population. But based on that, many researchers combined, it gives you a meta-analysis, which is like a high-end version of all the research, and based on meta-analysis it goes to the policy makers. Those policy makers will take a decision on what has to be done and what has not to be done. This is like in broad, in total, which I wanted to explain related to research. Make sure you draw this, and which is the best thing which you need to, which is reliable, that is meta-analysis. And this is one more thing which is given in Bayesian law. So I just mentioned about how metabolic response to an body during an injury. So you can just mention it. Might be asked for 5 markers, so I just kept it. Okay. Nothing else. I have explained majority of it. Though I am giving a disclaimer again, this is a topic, this is a paper which you cannot predict. So let me be very honest. Even I don't know what are the questions which can come. Though I have written everything over here, these are the broader way even I would like to study a day for exam. But the game of surgery paper 1 will start even before you prepare for your all the other paper, because here there are very less RS questions. And if you just to study RS question and go, you might kind of barely pass. Definitely all will pass at this stage and this era, but make sure you study little things extra also, because it's a competency based, competency derived paper, and these are the questions which will be like question bank to your juniors. So that's how it is. So make sure the surgery paper 2 doesn't go like this, because there are a lot of questions. So there are limited things, and there are limited questions which has to be asked from each chapter. So that has a easy narration. But this, though I can explain you everything here, but what comes to you at that point of time, make sure it's a general topic. Don't write generally, because write specific question in 1 or 1.5 page, then start writing generally, because it's more of patho. Then it comes to your research and all those things. Then it comes to all your ethics part of it. Then the first part is about the general surgery, where you need to talk about all the blood transfusion, the nutrition part of it. Then you need to talk about your major important things like sutures, all those things. Though all those things are important, you need to go and revisit those questions back. Though those are not the questions which can be repeated. I'm just emphasizing on the fact that you need to go and do a competency based revision for this. Though competency based revision is tough to do a day before exam, if you have just half day, make sure you study this so that you will just pass and come. Okay, that's it for paper 1. All the best.